Hey there, it's Katie from becomeagroupguru.com, and I'm here with Bess Child from Therapists Treating Self-Harm. Bess, thank you so much for being here today.
Hey, thank you for having me, Katie. This is awesome. I'm excited.
So I'm super excited too. I mean, for so many reasons, I think you're doing such amazing work for helping other therapists figure out how to effectively treat self-harm in their practice with their clients. I figured we'd start with you just telling us a little bit about what you do and how you do that. And then I have some exciting questions. Well, for me, exciting to ask you about what that looks like in terms of the group setting and treating self-harm. So give us a
Okay,
little overview.
that sounds good. So I am a trained DBT therapist. I was intensively trained about 5 years ago. I had started working with clients who were suicidal and self-harming in a residential setting. And then when I went into private practice, I thought that I was going to have to stop working with those clients. But instead, I kind of got bored when I wasn't working with those clients. So I started to really take on that as my niche. And so I have since kind of learned that like clients will come in telling me kind of what therapists are doing to treat them like before they come to see me. And a lot of the stuff kind of makes my head explode. So I was really working on trying to find a way to teach other therapists my methods of treating self-harm. Sorry, my T's are all like I have all these alliterations. So yeah, treating self-harm, teaching therapists how to treat self-harm. That's
You
basically
got
what
it.
I've been
You got
doing. So I have a Facebook group, and then I just recently launched a free training about that. And I've already rolled out a training in the past for therapists, and I know that you participated in that, which was really cool. But
Yeah.
that's really a passion of mine, and I want to expand it. So that's a long
Yeah.
answer to your question.
I love a long answer, and we both love alliteration. And
Yes.
so I watched the first of the three free or however many free training series that you put out. And I loved when you talked about, and I won't spoil the whole thing, but you talked about some of the myths and mistakes that therapists are making in treating self-harm. And one of the ones that I typed into the comments, oh my God, it drives me crazy when people do this, is that therapists will tend to like push the panic button and send their clients to the hospital for self-harming. And so, I mean, can you just talk briefly about why that's a mistake?
Yeah, because it drives me crazy too. And I think that I don't want to say that it's never the right choice, because I think sometimes it has to be the right choice if there are certain factors, and I go into that in the training a little bit. But I do feel that it's a big mistake because it's like incorrectly reinforcing the behavior, basically telling the client that if you self-harm, you're going to be put into the hospital, which I don't think those two should be connected. Plus, clients can be maintained in outpatient while they're self-harming, and it's not actually a life-ending or a lethal behavior most of the time. And that's why I think people get worried. I've seen my clients come in and they've been hospitalized for like superficial scratching, and I'm just blown away by that. And it's just, we want to maintain clients in our private practices outpatient rather than putting them inpatient and taking them out, because it causes a disruption. So as much as we can handle them in our offices, the better.
Right. And that's always my goal, is to keep kids out of the hospital, or for me, it's teenagers. So to keep them out of the hospital and maintain at the outpatient level. And one of the things that I found, just like in what you're saying, is that it ruptures the therapeutic relationship. That I have clients that come in and will say, you know, I've been afraid to be honest with my therapist in the past, because either they tell my parents about self-harm when that just makes everything worse at home. When we know, you know, there are certain things when there's imminent risk, we have to tell parents. But in terms of past self-harm, like, you know, I self-harmed 3 months ago. Is that something that we keep confidential? I guess I don't know if I'm asking the question or just talking it out loud, but
well, and that's like a whole different topic too, about like parents and breaking confidentiality. Like, when do you do that? And I got a lot of great questions in the training about that, and it's actually inspired me to create maybe like a mini training on how to support parents of teens who self-harm, because I think it needs its own like whole training. But to kind of like a short answer, I think that self-harm actually in my practice is kept confidential unless I feel that there's a danger of, someone ending their life accidentally. So for instance, if they cut on a major artery, or if they aren't very controlled about it, because a lot of self-harm is very controlled. So like if they're erratic and they just don't care if they end their life, then I would probably want them to share that with their parents. But I have methods that I use to share with parents rather than just like going behind the individual's back. And yeah, so
yeah,
it's important.
And that's one of the things I love about what you do, is that you do have these really clear-cut methods that it takes the guesswork, or I guess the clinician anxiety out of the process. Is that, sometimes I see these threads in other Facebook groups, like, what do you do in this situation and how do I handle this? But you've really covered all of those pieces about, let's take the drama out of this and just use the data that's in front of us. I know you're really big on data collection.
Oh, yes. I love to make this like illogical behavior, because really it feels illogical, it feels erratic, and for the individual who's self-harming, it feels out of control. So I like to try to make it as logical as possible, and a lot of my methods are around that, trying to kind of activate that rational mind and really make it about like tracking numbers and whatnot. So
yeah. And I think that's super helpful for us as therapists to take our own emotion out of the process. I know for me, like that's my niche too, is self-harming clients. So it's not something that makes me nervous. It's actually very much my comfort zone. But for a lot of people, self-harm does trigger panic in the therapist. And so having these really rational systems for how to respond to it is super helpful. Definitely. Can you tell us how, and then I'll get into groups, but tell us how having the niche of self-harm has helped the business side of your practice?
Yeah, that's actually really an interesting question, because I feel that the minute that I opened myself up to being like the go-to for self-harm treatment, I mean, my phone was ringing off the hook, and I run groups. And so I have 3 groups, but I also have a bunch of individuals, and I find that the individuals I like to work with that fulfill me are the ones who are self-harming, and that I can help stop self-harm. And, I'll follow them past that. But I feel like people, parents, especially of teenagers, will really invest in their child's treatment. So I find that I am full, no problem. And anytime I decide, hey, maybe I'll take on another client, I have, I don't usually take a wait list for individual therapy, but anytime I feel like I want to take on someone new, it's usually available to me. And usually I can ask within my group too. But self-harm has helped with that, has helped me stay full. And I would say people are like pretty much banging down my door to get in for individual therapy with me. So that's really awesome. And I do think that niche has helped with that.
And I think that like I want to pull out some of the things that you said is, number one, like you've positioned yourself as the go-to expert for this. So that's something like you've created an authority through your messaging and through your branding and through your marketing that you are the go-to person for this. And then the other side of that is when you work with a high-risk population, there's always that critical point where they need support. So I talk about this in my courses a lot, is like when you have any kind of offer, whether it's a course or a group or a service, like what is that critical point when people need your support that's going to help them. It's like the hinge for them to make a decision. And self-harm is such a critical point that, people, especially parents, but people in general, like it's dire. And so they're ready for the next step.
Absolutely. Yeah, I think that, obviously no parent wants to see their child go through something like that and to be hurting as badly as some of these kids are. So they really want to get their kids in for treatment. And a lot of times I'll have a parent who I've treated their child for self-harm, and they have a friend who comes to them and says, oh, my teen is self-harming, and then they'll send them to me. So it's almost like I'm not even really having to market myself anymore. Like in the beginning I was, but what's cool is that it's just like after a while, I just stopped having to even put myself out there. And I have physicians referring to me that I've never even reached out to. And so that's kind of a cool thing that happens like as I've developed this specialty.
And they know you, even if you don't know them. Right?
Exactly.
That's how it starts to happen.
Cool.
Yeah. All right. So I have group questions for you. And number one being that, in terms of a group, and I run DBT groups and you run DBT groups, right? But in terms of group in general, let's say for anyone who's running any kind of group, self-harm comes up as a topic. How do you handle the topic of self-harm within a group setting when, let's say, not everyone is self-harming? Like, how do you manage that?
Yeah, well, I think that it starts with the intake, because the intake, you really want to make sure that you're assessing for self-harm. And then if it's present, I usually give the individual and their parents a heads up, like there are other people in group who may or may not struggle with this, and kind of help them to understand the limits around it. I tend to then, in the group, like the initial group, the group guidelines group, where I go over all of like the rules and what to expect and how to make the space safe, we talk about self-harm specifically, and like talk about, discussions about suicide, discussions about drug use, discussions about
Yeah.
like sexual activity. And so all of those things, we kind of say, we want to be respectful of other people's triggers. But
Yeah.
one thing that I do, and is like a DBT, I think it's DBT specific. I don't know if you do this, but I term all of the behaviors that we do that are unhealthy, that we're in DBT group or in group to work on, as target behaviors. So everybody can get a benefit from the information. So when somebody's talking about, oh, I had an urge to use a target behavior, then it's not out there that it's self-harm specific, but that it is, and it may be something like you decide how you want to term that. But I think that's really been helpful, that I set that standard in the beginning. And you'll see that with a lot of the stuff I do, it is all about being proactive rather than reactive, because a lot of the individuals who self-harm are used to their environment just like reacting strongly to their intense behaviors. So we really want to cut it off at the pass before it even becomes an issue. And it helps individuals feel safe too, because those who self-harm, or even those who don't really want to be discussing it in group. It does come up once in a while, and usually I do a lot, of scanning the room and making sure that I'm keeping track of people's reactions. And then I will put a lid on it if it comes up and it becomes like too triggering for some people. So I don't know if that is that a good answer.
No, that's totally, it's a super comprehensive answer. And I do something similar. So like it does start with the intake process and managing expectations. I like what you said about terming them all target behaviors. I don't, and I know that term target behaviors is DBT, but I never have implemented that in my groups where like we call all of those things target behaviors as an umbrella term. The rule that I typically go over both in the individual intake and in that first orientation group is like, you're here to get support. And if you're experiencing one of these target behaviors like self-harm, suicidal thoughts, drug and alcohol use, things like that, that you can talk about it in terms of like wanting support with it, but there's absolutely no glorifying it. Like we're not coming into group and saying, oh my gosh, I was so wasted this weekend and it was hilarious. And we're not coming into group and saying, I had the urge to self-harm myself with this thing in this way, because my history working in a partial hospital program, like kids were learning how to do things that they didn't know before they got there. So I'm super sensitive to that. Is like, nobody's going to learn a new way to be self-destructive in one of my groups. And so that's something, it's like when I talk about marketing groups and overcoming objections, that's one of the things I'm constantly walking through with parents. Like we're very clear on the rules about what it is that they're allowed to share so that nobody learns something new.
Yeah, no, that's it. And that's also another, like going back to our original point about like not hospitalizing for self-harm. That's another reason why I don't like clients to go in for like very superficial self-harm, because if it's like just scratching or something minor that maybe we can overcome quickly, then they go into a partial hospital or whatnot and they learn lots of things. But that is a really good point, to make sure that it's a safe place and that the parents can also trust that their teen or their child is really safe in that environment, and that they're not going to take on new behaviors. Yeah, definitely.
So I have a question for you, like from my my teen support center, my personal experience, and also my clinicians that work for me. We've been coming up against but we've been experiencing this idea over and over again. And since you're the expert in this area, I'm hoping you have some insight. Is that so? We'll have clients that are in group, any of our groups, process group, college prep group, any of them, and they have peers who are self-harming or suicidal. And so that becomes a topic of group. And typically I defer to like a boundaries type thing, like self-care and boundaries. But like, I'm just wondering your thoughts on how do you address it when you have either individual or group clients coming in and talking about their peers self-harming?
Mm-hmm. Yeah, I mean, I think that it's helpful to have like a mix of the individuals who aren't self-harming. Maybe they've observed it in their peers, but then there are the individuals who are self-harming, or maybe those who have recovered from self-harm within group.
Yeah.
Usually, I have like a variety of
Yeah.
different, and so I tend to. And I don't know if everyone feels this comfortable with their group, but after I've established some rapport, I feel really confident about like trusting their responses. So a lot of times I will put it back on the group and ask them kind of like, so what do you guys feel like if anybody's ever struggled with this, like how would you want a friend to approach it? Obviously, if I'll be mindful of the language that the individual uses to bring it up, because sometimes like it's all about how it's termed, whether it's triggering or not for the group.
Yeah.
But say somebody came and they said, I have a really good friend who just started self-harming, like, and I'm not sure what to do. It might be something that I, put back on the group and I say, like, is this something that we feel comfortable talking about?
Yeah.
And is there anybody that has an idea of like how you might want to be approached if you were in this situation?
I really love that. And I would agree with you about trusting the group. I think that you get a feel for your group and you can throw things back at them. And in my position, it often fuels healthy discussion around it. Like maybe
Totally.
one person would want one thing and one would want another. And then I'll say, okay, cool, debate. Like what do what are the differences? What are the similarities? So it helps the group kind of connect and create their own solutions.
Yeah, absolutely.
Yeah.
And I mean, some of the most incredible things come out of that. And I think that a lot of the teenagers in high schools are really controlled in what they're able to kind of offer. So to give the opportunity for them to be kind of the experts in this experience and give some feedback to their peers, like how have you been approach that you didn't like what was not helpful, what was helpful. And I do a lot. I don't know if you teach the biosocial theory in your group. Yeah. So I remember like when I first learned DBT, they didn't teach to bring in biosocial, but so talking about how the environment can invalidate, I think can bring up a lot of that, can support that discussion too. And so I might refer back to that group because usually we do that in the first or second group.
Yeah.
So yeah, and that could be brought into any group setting, I think, is, discussing like how it is to be a highly sensitive person or someone who has big emotions or someone who struggles with whatever the group is dealing with. How is that to be in your environment, and how do you wish your friends would react?
I have a really great, it's like 4 or 5 pages that an old supervisor printed out for me. I don't even know where it comes from, but I'll pull it out and try and find it and share it with everyone. It's like all these examples of invalidation, like all of the things that people say that invalidate. And sometimes I'll just pull it out in any of my groups, not even DBT, to just be like, have you experienced any of these things? So I think you're right. Like the idea of talking about friends suffering or kids suffering or parents, whoever the group or individual client is talking about someone else who's suffering, it's a good opportunity to bring in discussion about validation. And I know validation is a topic that you have a webinar on validation. You talk about it a lot. So it's something that you're really versed in.
Yeah, I'd say that was probably like my number one clinical skill. And if I would say that most of the time, a lot of my clients who have been with me for a really long time know that, and they will be like, oh, that was super validating, Bess. But at the same time, I don't offer a lot of advice or critiques. And I usually don't push towards change as much as some therapists might. So that's another thing that I think has helped with my work with self-harm is obviously I think that these individuals have gotten so much push for change. Like you have to stop doing this. And that's one of the mistakes I talk about, is like telling your clients you need to stop. But that's actually kind of dangerous because then they're like missing a big coping skill. But yeah, I do use a lot of validation, and sometimes validation actually can help fix whatever it is that's going on. It's pretty incredible. So
yeah. And I find that, validation is probably my number one tool too. I went to a training and the woman said, and I was already doing this, but she said, don't let anyone tell you that validation isn't an intervention. It's one of the most powerful interventions. And so like a little personal, like I grew up feeling highly sensitive and feeling like I was crazy for having the feelings that I did. So all I ever wanted was somebody to tell me like, yes, that makes sense that you feel that way. You're not insane for having feelings. And so
Right.
that was really important for me to bring into my practice. And I, like you, find that it's such a helpful tool in facilitating change between validation and assessment on an ongoing basis. Like,
Oh my
I think
gosh.
they create the greatest insight and change more than anything, more than forcing change.
Absolutely. Yeah. Assessment is super awesome too. I'm really into that. And that's most of, I would say that's like majority of my treatment is also assessment over and
Yeah.
over and over again, not just during intake.
Right. Lori says, I love this topic as a ton of my clients who are also teens express feeling so invalidated. So it's super important. And Beth, you said, and I don't know if it was in your free or your paid trainings because I'm in one of your courses. So, but you said that assessment is actually something that helps your clients feel validated. Can you talk about that?
Yeah. Yeah. Because one of the levels of validation that I teach about is like all about expressing curiosity and asking lots of questions. And that's something that I teach parents because that's one thing that they feel really comfortable doing is asking questions. So like if they don't know and we all need to assume that we don't have all the answers when we're talking to our clients, and just asking lots and lots of questions can feel valid because you're interested, you want to know, and you want them to be the expert. So assessing them helps them to feel that way.
So, and I have a few thoughts about why that's so helpful, but I want to also, like, I don't know, just unpack for a second that the question shouldn't be, why do you feel that way? That feels so accusatory and attacking. It has to be actually like questions that come from curiosity, right? Yeah. Like, what was I going to say? Oh, not assuming that you know what the actual problem is. That's what I find to be helpful in terms of assessment. Like, you as the parent or the professional might assume that it's this one thing, but it needs to be questions that understand what they see as the problem. Does that sound right?
Absolutely. Yeah. You can't assume that you know. And even like after I've done this work for so long and I feel like I've seen every different type of self-harm from one extreme to the other, I feel like you can't assume. I do suggest that you have like some typical experiences in like could it be like this? Or I'm wondering if you experience it this way because I've had another person who experienced it this way. I think that that's helpful. The other thing I was just thinking about when we were talking, we could talk forever. Like
I know, I don't even know what time it is, but you can keep going.
It's 10:53. I have a call at 11:15, just as long as we're done for then. But I was thinking about how we don't just need to assess too when things are going badly, like when self-harm is present, but I also assess when self-harm is not present. I want to know, okay, so why didn't you self-harm? And so a lot of my questions, my clients are like, why would you ask me that? And then it like leads into this really great discussion. But when you ask like, so what made you not? And like, what was it? What was different? So assessing those things are super important too.
Yeah. And I think that also connects back to data collection, right? Like, I do diary cards in my individual sessions or like a modified version that works for my clients. And so I ask the same kinds of questions, like, well, what was different this time that you coped in this way versus in this really unhealthy way that you did last time? So
yeah, exactly.
So give us like your top, as of today, your top like 1 to 3 tips for clinicians if they're working with clients who self-harm in their practice, if they're looking to start any kinds of groups. What would you say is most important for them to start to think about?
Well, I think number one, you probably should take a step back and do some self-reflection on what your own limits and boundaries and comfort level is, because I'm comfortable with this doesn't mean that everybody's going to be comfortable with it. And because, you, Katie, are comfortable with it, it's not going to be that every therapist who decides they want to treat self-harm is comfortable with every different type. So, for example, I don't feel super comfortable treating skin picking. It's like one thing that has come up a lot, and I feel like it's out of my scope and the treatment I use doesn't work as well. So that's something where I refer out for those types of self-harm. So that's just an example.
That's how I feel about eating disorders. Like, I can't.
Exactly.
I just don't feel skilled enough to handle that. Yeah, go ahead.
And eating disorders are very, very challenging. And the people who specialize in them are like badass at treating them. So you do you. I also think that it's super important to make sure that ahead of time you have separate assessment for suicide and separate assessment for self-harm, especially during intake. And that's really important. You need to have completely different questions, and they need to be a different conversation even. So you can't just ask the umbrella, are you feeling unsafe? It just doesn't work.
Yeah.
And then I also think that it's meeting the client where they're at. That's so cliche, but like really it goes back to that. It's figuring out how to be open-minded, shift and be flexible, but really meeting the client. So.
And does meeting the client where they're at, because I know my answer for me, does that mean that if they don't want to work on self-harm right away, that you're willing to work in other areas that kind of at the same time, like maybe extinguish self-harm, but it's not the main target for treatment?
So, yeah, I mean, I think that if somebody's not ready to work on self-harm, I tend to refocus on commitment and find out like why and what the goals would be. Like, what about their life is, worth living if they stop self-harming. I feel like it's really important to get to that point where it's figuring out like what are your limits. For a while I wouldn't allow my clients to come into therapy and not talk about self-harm, because that's like with DBT, that's a rule a lot of times, is that you have to talk about that and suicidal ideation. I've pivoted a little bit with that, because I feel like working on reasons to stop self-harming is just as important as like figuring out why they're doing it. So they need to have a motivator to stop, so that we can start understanding why they're doing it and what to do instead. So.
Right. And I think that makes total sense and kind of fits in with like, I sometimes, if they're not willing to work on that part of it, it's like focusing on, just like you said, what makes their life worth living, almost to the point where like the self-harm becomes, it doesn't fit in with their life anymore, right, because the other parts are working so well.
Exactly. Yeah. Yep.
Awesome. Tell people where to find you, and I'm going to link the your free training series in the comments too, but tell us where to find you and what's going on in your therapist treating self-harm business right now.
Yeah, so I have a small group, or actually it's getting to be a big group. It's over 300 members now, which is awesome. It's called Therapists Treating Self-Harm. So join the group. I've decided I was going to only keep the recording replay up until last night or yesterday. I forget what day it is.
Doesn't matter.
Anyways, I'm going to keep it up until midnight tonight, because Katie and I were going to be doing this live stream. So it'll be up until midnight. So make sure you watch it. And once you sign up, you'll sign up for all three. So you'll be able to see next Wednesday at 12:15 Eastern time. I'll be doing another training on coping skills and how to insert coping skills. And then the final training will be next Friday at 2 p.m. Eastern. And I'm going to be talking about like my real secrets to what like the very core pieces of my treatment model. So I think that that's going to be really awesome. And then I do hear everyone's need for, a lot of people are asking about how to work with parents, and I'm trying to kind of formulate how I'm going to deliver that. But I think it may come in a bonus, so look out for that.
So if you are a therapist and you treat self-harm in your practice, or you're looking to treat self-harm in your practice, or figure out how to not have to refer out and further niche in your practice, connect with Bess, join her group, Therapists Treating Self-Harm. She has a free training series right now. Next week or this week, you're talking about how to plug in coping skills that work for your specific client versus just, general coping skills. And then you're sharing your super secret sauce. There we go with our alliteration for how to effectively treat self-harm in your practice, including a possible bonus training of some sort of how to help the parents of clients who self-harm if you work with kids or teens. Awesome stuff. Thank you for being here.
Thank you for having me, Katie.
I'm going to link all your resources below. So anyone who's watching or catching the replay, go ahead and check the comments, and I'll have some resources for how you can connect with us. Talk to you soon.
Thanks.
Bye.
Bye.
Bye, everyone.